Good morning or good afternoon, everyone. We'll get started in just a moment, as soon as we get the slides up. Thank you, everyone, for joining. My name is Irene Navis. I'll be one of your facilitators today. I'm under contract to UCSF, and I am the PPN CBRN Domain Manager and helping support this DRC effort. Thanks again for joining. Go to the next slide, please. Just some quick acknowledgments and disclaimer. The PPN is supported by HRSA with the Department of Health and Human Services as part of cooperative agreements. And this content that you're going to hear today is that of the authors and doesn't necessarily represent the official views nor an endorsement of HRSA, HHS, or the US government. And then if you want more information about HRSA, please visit hrsa.gov. Next slide. Then we have learner notification for accreditation purposes and credit designation. I won't read that whole slide to you, but this session is available for CE credits for certain folks. And so at the end of the session, you'll learn more about this, but here's just some quick information about how to obtain credit designation and continuing education credits. Next slide, please.
Great.
And we have, sorry, I just wanted to mention real quick that we have no disclosures at this time for any of the speakers or any of the content. Thanks. Go ahead, Dr. Blom.
Thanks, Irene. Hi, all. Thanks for joining. So our learning objectives for today are going to be to describe pediatric decontamination strategies, identify progress made in decontamination and preparedness at the participants at your facility, and then review different tools to use when planning for exposures to CBRN agents, and to identify any resource gaps and needs to complete preparedness activities at your site. We can go to the next slide. So as far as what we're going to cover today in our agenda, after reviewing this agenda, Doneen is going to provide a recap of the June session on measles. And then we'll have a poll question related to your team's progress on the TICD preparedness activities. We'll do a brief presentation or preparation discussion for the August large group prep. That's going to be our next meeting. We're going to meet as a large group. And we will be, just a heads up, we're going to be requesting for representatives from teams that have participated in the TICD virtual tabletop to share their experiences with the virtual tabletop, any lessons learned from that experience. And then today, we're super fortunate enough to have Dr. Brad Goldberg present on pediatric considerations for CBRN decontamination. And then we're going to have a brief Q&A session after that. We'll then have facilitated breakout groups, or may just stay as a large group, depending on the numbers today, where we'll discuss the presentation takeaways, the strengths at your programs, and any gaps at your programs. And then just discuss next steps. We'll then come back. If we are doing breakouts, we'll come back to the large group and then provide a recap and then priorities for our next session. And then there'll be one final poll question for the group, identifying any resource gaps at your sites. And then we'll review DRC next steps. All right, you can go ahead to the next slide. Doneen. So Doneen is now going to give us a recap of the June session. Thanks, Doneen.
Yeah, thank you. Hello and welcome. So to recap our June session, we did go over some key components. We'll go over some key components of last month's meeting. During that time, we utilized the EMSC checklist of essential pediatric considerations for every hospital's disasters policies. And we really use that for guidance and to focus on exposures. And those are the three types of exposures, whether it be infectious disease, chemical, or biological. But really during the June session, we focused on an infectious disease exposure, and we did that through a measles simulation. During that meeting, we really reaffirmed and operationalized the isolate, identify, and inform framework. which is a fundamental process for managing suspected infectious disease exposures in real time. And really, this approach ensures that responders and facilities can first isolate. So you want to make sure we isolate the patient promptly to prevent further exposures to other patients and bystanders. Then we want to identify the signs and symptoms, travel or exposure history consistent with whatever that high consequence infectious disease is. And lastly, inform. And this is super important. We need to make sure we inform both the appropriate internal leadership as well as public health partners quickly and clearly. After that, we briefly walk through the hierarchy of controls as it applies to infectious disease exposure, especially in the healthcare and the emergency response setting. This model really helps us systematically reduce risk from the most affected to the least. And some of the key items that we utilize here would include elimination, substitution, engineering controls, administrative controls, and lastly, PPE. And our hopes are by layering these controls and not just relying on one, we can protect our staff and our patients. And the goal is to push our response as high up through this hierarchy as possible to reduce any dependence on just the PPE alone. After we reviewed those concepts, we moved on to our interactive stimulation exercise. So we led a practical interactive stimulation, and we really designed it to help you and your team think about applying the isolate, identify, and inform protocols for your institution. We also wanted you to evaluate your practice for pediatric triage under an infection control constraints. We wanted to evaluate the readiness of your current decontamination procedures, and most importantly, really to identify potential gaps in your plan, in the processes, and also in training. So this exercise was intended not only to strengthen coordination, but also to welcome open discussion and real-time feedback as we all work together to enhance our processes for pediatric disaster preparedness. So hopefully we met some of those metrics with you guys last month. Okay, moving on. Is it back to you, Nick? Or Irene?
The poll question? Okay, just what we'd like to do is assess how far you've made it into progress on your preparedness activities for under this TICD focus area. And so you're going to see a drop-down menu, and we're asking you, oh, the polls are not launching. Okay, sorry about that. So what we're going to do off of this slide, please use the chat. In addition to introducing yourself, if you haven't already, take a look at this list and select all that apply in terms of where you are in progress. So are you just getting started on plan updates? Are you complete with your infection control response plan or your CBRN decontamination plan or annex? Have you participated in a DRC hosted tabletop exercise, completed an after action report based on that exercise, or have you worked on a facility led infection control exercise? Have you scheduled it? Have you completed it? Let's see. Facility led decontamination exercise scheduled or completed. And whether you have completed after action report. So could be all of the above, it could be none of the above, but hopefully you'll have at least one of these identified in your progress. And then later on, we're going to talk about perhaps some obstacles to your progress and what resources you might need in order to complete these steps. And if there are other steps that you've completed related to the TICD that aren't on this list, go ahead and put that in the chat as well.
Sorry about that.
No problem. That's why we always have a plan B. Thank you, Laura. And I know there's just a few of you on. in the collaborative. So just go ahead and put as much as applies in here. And thank you to those who have already introduced themselves. And I want to acknowledge Dr. Walter. He's one of our designated subject matter experts that's participating in this process. And we're very excited to have him on. His schedule is probably the worst of all of us. And so he can't always join us. And so we're so grateful to him for him to be here today. Great. Thank you, Mark. And thank you, Donnie. Thank you, Johnny, Carolina. Hi, Tyler. So good. I'm so glad you could join us today. Tyler's going to be a future speaker for us. We're looking forward to that. Okay, just give it another couple of minutes. If you're just now joining us, we're on this poll question number 1. You see the options there on the slide, and we're asking you to list the status of your progress in the TICD preparedness activities. We're asking you to list those in the chat. So we'll just give it another couple of minutes before we move on. See a few folks on here who haven't weighed in yet. And if you haven't made any progress, that is no problem. Just state that in the chat that you have not gotten started yet. And then later on, we can talk about what we can do to help you move forward.
It's definitely nice to see some facilities utilizing the DRC tabletop exercises to help them with this initiative. So that's good to see.
For sure. Yes, we'll have to make sure that we let the drills and exercise folks know. Very good. Thank you so much. Of course, the chat's wide open. And so if you think about something later or you want to add to what you've already listed, you certainly can do that. So let's go on to the next slide. Okay, in preparation for August's meeting, and that's August 5th, that's the collaborative where all of the focus area groups get together and discuss progress and issues relating to the whole group and give some status reports of where we are in the process. And so those who have completed the DRC virtual tabletop exercise, if you have something you'd like to share today, we'll take a comment or two about your experience. And then if your facility has scheduled an exercise and it'll be completed by August 5th, if you would like to share that with the entire group on August 5th, there'll be a carve out of time on reporting on the tabletop exercise experience. We'll have template slides that are provided, and your talk should be somewhere between 5 and 8 minutes, hopefully more on the 5-minute side. Thank you, Bridget. No problem. Bridget, if I know that UCSF has done an exercise, but I think it was on reunification. But certainly you can mention that here. But if anybody who's done the TICD exercise process, if you want to speak up now, just give you a moment. or talk about the exercise process in general. Any comments? Shy group today.
Hi, Mark Baker.
Hi, Mark.
We did the DRC virtual exercise last month, and along with a community hospital, a general hospital in Portland. And I thought it was pretty helpful. We got a couple things. We had written a decon annex, and basically we used the exercise to test that. We tested out a recall process. We were able to get like 25 people, I think, to respond that they could come in within 15 minutes or so, but that was during the day. So, and then a couple other things that kind of came up that we made some revisions to the plan, but now we're finishing that up and then submitting it for our to be included in the as an annex in the emergency operations plan for the hospital. So I thought it was helpful.
That's great. So you were able to identify some gaps or areas that maybe you needed additional information that needed to be plugged in. That's great. And then that's a very important test that you did, the call in or recall. One thing I would suggest is try a scenario where it happens on a weekend or on a holiday or in an evening. Just from experience from two major disasters that I dealt with in Las Vegas, one being the Carpenter One fire, which is the anniversary today, the 12-year anniversary. It happened on 4th of July weekend, and finding responders that weren't at a barbecue or some other time off was extraordinarily difficult. And then, of course, our Las Vegas shooting in October of 2017 was at 10 o'clock at night on a Sunday. So those recall procedures can get really derailed by time of day and time of year. Would you be willing to be one of the speakers on August 5th to report your progress? And perhaps by then you'll have your after action report completed as well. Would you be willing to share with the bigger group?
I think so. Or I can ask our emergency manager, or Shay During. He's also part of our DA.
Great.
So
Great. We'll follow up with you. Thank you so much. Anybody else want to speak on this or have any questions about the tabletop exercise process that we can answer? Okay, let's move on to the next slide. Okay, Dr. Glom, I'm going to toss it back to you to introduce Dr. Goldberg. Thanks.
Great. Thanks a lot, Irene. Yeah, we're incredibly fortunate to have Dr. Brad Goldberg present today. Dr. Goldberg is a pediatric emergency medicine physician and also the medical director of emergency management at Children's Hospital Los Angeles. He also serves on the California State and National Disaster Medical System, NDMS teams, responding to emergencies beyond the hospital walls. So Dr. Goldberg, thank you very much for being here today. Go ahead and take it away.
All right. Good morning or good afternoon, depending on where everyone's listening from today. I'll start by I have no relevant disclosures to mention before starting. And I would like to just give me 1 second here. Can we all see the slide? Okay, perfect. So I'd like to start with like what this talk is going to cover today and what it's not going to cover. I wanted to really give a visual overview of what the process of decontamination looks like. And I think a picture or a video is worth 1,000 words. We can read best practices and protocols, but to actually see what it looks like, I think identifies a lot of challenges. I can speak from drills we've done. We've learned so much from drills and exercises, and we constantly are finding gaps and areas we need to improve. So I hope today's overview will spur questions about your plans, identify potential gaps. I am not here today to tell you what you should be doing, but really to just overview the whole process for all your team members. We will not be getting into the toxidromes and the pharmacology today. There are courses that are great for people that want to learn more, particularly on the clinical care side. Advanced Hazmat Life Support is a great course that I personally took and learned a lot from. So that is one I can recommend. So we're going to kind of jump into starting with what the differences are between a center's normal operations and decon and CBRN operations. And for the purposes of this talk, we're really going to be speaking about chemical decon today, particularly around organophosphate poisonings, which can be from industrial accidents, could be terrorism, could be completely accidental. That's going to be the premise for a lot of these slides. We will talk a little bit, very briefly, on radiological surveys for radiological decontamination, but that's not the main talking points here. And CBRN is a term we're going to be using throughout the talk, but as you already know, that encompasses a lot. That's blast injuries, explosives, biological, and for each one of those situations, these plans are going to be different, and the equipment being used may be different. So what you can see in front of you on the slide now is how typical operations work. You basically have two entrance points to the hospital or medical centers. You have self-arrivals and you have EMS runs. And depending on your center, there could be different entrances for these. There could be different triage areas for these, with the goal of ultimately getting all patients through triage and into a treatment area of an emergency department or acute care setting. Next slide, please. The differences when talking about a decon operation is you still have the issues of these patients arriving from two different areas. They will be self-arriving and you'll have EMS runs. All of these patients, however, are going to have to go through a triage section, which will include administering interventions and antidotes for emergency considerations that are life-threatening immediately, and we'll talk about those, getting those patients safely through decon and into a treatment area. And you can see the transition from the yellow to green areas on this slide. The yellow area is the warm zone or the contamination reduction zone. In this situation, we're talking about people who are arriving from a distant event and arriving contaminated to your institution, not an event actually taking place at your institution. So those situations will be handled much differently. And then getting them ultimately out of that contamination reduction zone, clean, deconned to the cold zone or treatment area. Next slide, please. So here we're just showing some visuals of what decon may look like in different situations. You know, where I work at Children's Hospital Los Angeles, we're very fortunate to have a decontamination shower, which you're seeing here, but this is often an asset or a resource that most medical centers may not have. So what does your decon, apparatus do you have at your centers? Next slide, please. This is another example of a different decon apparatus. So this is a mobile trailer on wheels that you may have as a resource to your center. This may be something that is borrow or loan to you. Questions about when thinking about your plans is how long would it take you to get one of these devices stationed outside of your institution? What's the process for getting it there? I can tell you, having seen these things being taken out of storage and set up, there's maintenance issues with them. It takes a while. So this is not just something you can snap your fingers and have set up outside of your institution. And take note, we'll talk a lot about pediatric considerations, and you can see the baby on the stretcher there, and we can all identify a lot of issues with that photo. Next slide, please. Here's another example of a decon in process, and you can see that this is in another mobile apparatus with a patient who's going through on a conveyor belt system with the backboard. Next slide, please. So we talked about all patients will have to be funneled to a triage and immediate interventions and antidotes area. This could be in different places, and you have to think about in your plans where this will be taking place, how you will get patients around your institution, either outside externally or internally through safe passageways that are cordoned off. So we're very fortunate here in Southern California. You know, we have a pretty temperate climate. We have a large ambulance bay outside. You know, we could do year-round operations outside the ambulance bay, but that might not be feasible depending where you are in your country, where you are in the country. So talking about immediate interventions and antidotes, these are things that all patients should be screened for before they go through full decontamination. These are immediate life-saving interventions. So this is not waiting to decontaminate these patients fully. So these are opening and maintaining an airway. Spinal motion restriction is needed, so that's backboard and seat collars. If the patient has a pneumothorax, to perform needle decompressions. Stop the bleed, so control of massive external hemorrhages, placing tourniquets is needed. And of course, for a chemical exposure or organophosphate poisoning, using antidotes as soon as possible. And, you know, we see here intramuscular injection via auto-injectors, but your centers may not have those. And those auto-injectors might not be, if you do have them, might not be the right dose you need for a pediatric patient. So that is one area that we're going to talk about a little bit further. This was adapted from the Advanced Hazmat Life Support Provider Manual, and this is the course I mentioned in the beginning that I think would be a good, more advanced class to take for those that want to get more into the nitty-gritty of the pharmacology, the toxidromes, and the treatment of these. Just want to note that the auto injectors that are being shown on the slide, these are no longer in use. These are discontinued. This is just the best photo I could find of what these auto injectors look similar to. You can think about an EpiPen as another type of auto injector that you might see more regularly. So just note that these older auto injectors are no longer in use. Okay, next slide, please. So I'm in Hollywood. I like movies. That's where I'm talking to you from today. So what you may think of, or what patients may think of when it comes to antidotes, is not like what you see in the movies. The photo on the left is a scene from the beginning of a great movie called The Rock, and Pulp Fiction on the right. This is not how we administer antidotes. They're not these large needles that you have to inject into the heart. Next slide, please. So once again, just prefacing that these specific auto injectors that you're seeing in the photo, these kits are no longer in use. I just thought they were a very clear up close photo for you to see what an auto injector might look like. These are standardized doses. And these are for specifically organophosphate poisoning. So this is atropine and pralidoxime, which are both used. Once again, we're not going to get into the whole toxidrome and pharmacology today. But many medical centers do not have immediate access to these auto injectors. So you may have to draw up individualized doses from vials. So that raises a lot of question, you know, what dose for what pediatric patients? And we'll talk a little bit more about that in the coming slides. So next slide, please. Okay, so once again, we are getting patients from two different avenues, the self-arrivals, the EMS runs. We have to have an area to provide them these interventions and antidotes with staff that have the relevant PPE on to work hands-on with these potentially contaminated patients. And then ultimately, we have to get them through triage and decon. So next slide, please. So that's currently where we are. You are here. So talking about some pediatric considerations, this slide I adapted from our Disaster Resource and Training Center here at Children's Hospital Los Angeles, and all credit to one of our emergency managers, Vicki Olson, who created the following two slides, which I think are fantastic. So when we are thinking about our decon plans, this is what we see. We see staff members, we see them wearing PPE, and we see them helping a victim and providing life-saving interventions. But that's not what children see. Children have no idea what's happening. This is a very frightening scene for children. Next slide, please. So what do the kids see? So they see something like this, right? They think about to what their reference points are. So they think scary things. They think Darth Vader. They think monsters. So what can we do in developing our decon plans that keep this in mind throughout, from beginning to end? So how can we adapt our plans to make them more friendly for children and pediatric patients? Next slide, please. So one recommendation I have is, work with all of your local stakeholders. And I just listed a few here. There's many more. So consider enlisting child life, your social workers, family medicine and community pediatric clinics, and community and faith leaders. And what you're seeing here on the left, this photo of this is actually one of my colleagues that I work with. During the beginning of the COVID-19 pandemic, when we were in pretty extensive PPE, and you can no longer see the healthcare provider's face, or even for a young child understand that there's a human underneath all that PPE, we were printing out these kind of giant face cards that staff could wear over their PPE, just to give another reference point to help a child potentially understand that it's a human underneath there and that they may be trying to help them. Next slide, please. So another resource that we developed at Children's Hospital Los Angeles was a decon picture guide to help children and families understand what is happening during a decon shower and process, and make it more children accessible. And the reference for this is at the bottom. This is publicly available on our website. We can go to the next slide, please. So as you can see here, recommendations for what's happening at each step with easy picture visuals for the children, as well as translation to multiple languages that are common in our treatment area here in Southern California. Also with prompts for the healthcare providers about what to say that's developmentally appropriate for a child who's undergoing decon. And think back to those photos of the decon showers we showed you, because we're going to reference that and then this picture guide in a coming slide. Next slide, please. So the next question I want to ask is, how do we adapt these plans to accommodate children and youth with special healthcare needs? There's a lot of considerations and a lot of logistics to taking a child through a decon who carries one of these diagnoses. The chair that an electric wheelchair is the cost of a nice car. So what measures do we have to potentially protect or salvage these devices and get them through decon? And there's that's kind of like could be a talk in its own. What about an autistic child? How do you get them through a decon? These are very challenging questions. And once again, I'm not here to provide you all of the answers, but I want you to consider these things when developing your plans. Where do you store all of this contaminated equipment that belongs to patients during this process? If a child does have to be parted from that $40,000 electric wheelchair, where is that going? Do you have plastic? Do you have the appropriate size plastic bags to bag this stuff in if being stored outside in that warm contamination reduction zone? So these are things to consider in your plans. Next slide, please. So we talked a little bit about the antidotes, the different medications that we'll be using during a decon and antidote and a chemical event that requires antidotes. So there are assets, strategic assets stationed around the country called chempacks. And what these chempacks are large caches of antidotes for organophosphate poisonings. And you're seeing a picture of a hospital chempack item list. So my nearest chempack, this is what's in it. So everyone should be asking the question is, where is your nearest chempack? How do you access it? And what's in it? And are the contents of it appropriate for all of your pediatric patients? So the answer is there are a lot of multi-dose vials in there where you can weight base medications, and there's a lot of the auto injectors in there, but those might not be appropriate for every patient in every situation, and we'll see why. Next slide, please. So this just highlights how I might feel if I had multiple patients with an organophosphate toxidrome presenting to my institution, and someone was asking me to draw up the appropriate weight-based doses for all those different patients, and they're all going to be different. When these auto injectors and these antidotes were first developed, they were developed with the military in mind and for adult age and sized patients. So that's why we don't have auto injectors for every for every pediatric weight range. So don't feel like this when developing your plans. Enlist your pharmacists. They will be an invaluable resource in determining what is going to work, what's going to work well for your institution based on what medications you have on hand. Who's going to draw them up? Do you have a pharmacist that's going to be drawing them up? Is your pharmacist 24/7 in an emergency department setting? Do the nurses need training on these medications, which they might not use frequently, particularly the pralidoxime, and how to draw them up quickly and efficiently? Next slide, please. So the following are just examples of different pediatric-friendly weight-based antidote dosing. This is just an example that was pulled from Department of Health Services in Los Angeles using a weight-based color-coded system very similar to a Broslo tape in determining what auto-injectors to use for different weights and what doses of each medication to be used depending on the patient's weight. So always refer to your local protocols and policies. And if you don't have ones that work well for you, develop your own. Work with the local stakeholders in developing what works right for your municipality or treatment area. Next slide, please. So I want to preface that this here, what you're seeing, was my attempt using an AI, a language model, to develop a novel system for pediatric medication dosing. This is not for clinical use. This chart is incomplete. It's missing important data points, but just serves as an example where you can use AI tools to start experimenting and developing alternative dosing schedules that work for your institution based on what you have. So when I prompted the AI to develop this, I said, I have auto injectors based on what is in my chempack that's accessible to me on site, and I have vials. Can you create a more simple weight-based approach to which medication to use in which situation. So once again, this is incomplete. Please do not use this or reference this, but just to highlight that maybe a different system is going to work better for your needs. Next slide, please. So we're going to do just a rapid scenario. You get a call about a potential organophosphate chemical event, and you have a child presenting to your emergency department. You had maybe 20 minutes notification prior to their arrival. They look like they're 7 to 9 years old. They've been having lots of secretions and wheezing en route, and the patient started seizing when they pulled up to your ambulance bay. And this presentation is consistent with an organophosphate poisoning. Next slide, please. So this child got antidotes, and now they're somnolent. Their respiratory rate is 12, and you're not sure if you can feel a pulse. So this is just a slide to highlight you have to incorporate a triage system into your decon and antidote plans. It's not important. I don't care which triage system you're using. I think it's most important to pick a triage system that works and is in alignment with your local protocols and policies and what works for your institution, and make sure that everyone is well trained on it. So this is just an example using the Jumpstart triage algorithm. And this patient would be triage to immediate. Next slide, please. So into the decontamination we go. We've gotten past triage. Next slide. Now decon. And remember, when you start the process of deconning your patients and showering them, you also have to have a plan on the other end to keep them dry and warm afterwards. As we know, children are very susceptible, way more so than adults, to hypothermia. Next slide, please. Okay, so the goal is to get them to that treatment area cold zone. Next slide. And here we're going to show a quick video just with some visuals of what this process in totality might look like. So first off, team building. I just want to highlight, you have to train with people that are going to work together in an event like this. Our hospital has found that having a decon team that trains regularly has been very helpful for us. And just pay attention in these photos that you're seeing, and you can continue playing the video, sorry. How many people it takes and how much space you need. We're suiting up in this picture and the following one about 4 responders. So each responder ideally needs another team member that knows the process to help them don and doff, and taking into account how much space you need. Do you have pre-assembled kits for different size responders? Because it's not one size fits all. Next up, considerations, team safety. It gets hot in those suits. I've spent a few hours in them. It's exhausting. What processes do you have in place to figure out who goes into these suits and how to monitor them? And here's just an example. That was a mannequin. That was a mannequin. We were simulating a provider down that had collapsed in a respirator setup. Triage. It's one thing to tabletop it, but it's another thing to put on all the equipment and go out and actually do the triage in full PPE in an actual environment and not standing around a table. Is it inside or outside? You can see an antidote being given here into the thigh in PPE. There's a lot of tactile training you need when wearing these suits. It's not as easy to open things and administer things when wearing those thick rubber gloves. What apparatuses do you have? Back to the different types. So you can see here a team figuring out how they're going to get a non-ambulatory patient on a backboard through this decon trailer. And the team is practicing working out how they're going to get the patient safely off the backboard and through that trailer. Think about what it would be like for a child to be on this backboard and then going through the trailer. Very, very difficult. Some of these decon apparatuses are clunky. They present safety issues. Look at the steps coming down. Those are hard for a child to get down. So we can pause here for 1 second. So this is our decon shower here at Children's Hospital Los Angeles, and you can see a medical team undergoing decon in their suits. We talked about ways to make these situations more child accessible and friendly. We realized and we got a lot of feedback that our showers weren't very welcoming. They could be quite scary when you see this, obviously. So we're working on different ideas of making giant laminations of our pediatric decon picture guide and maybe placing those on the wall and try and just make the shower overall more inviting. So that's a relatively easy intervention. We can continue playing the video, please. And this is all just to give you an idea of what this looks like in the real world. So here, there's a patient, a pediatric patient being deconned. In the first basket, we realized, hey, these baskets don't have holes in them. They're not going to drain out. The second video, we were able to get baskets with holes that allowed for the water to drain and not pool. But then we realized, hey, you know, these scrub brushes that one of the teams were using have really thick, coarse bristles on them. Those were way too intense for a young child's skin. So then learning from our exercises and getting baskets with holes in them, finding more soft sponges and cloths to decon the patients with. These are all things you're only going to learn through exercise and exercising with pediatric patients. Also, this is the special call out to radiological survey for radiological decontamination. You know, get your team's hands-on with these devices. It's the only way they're going to learn to use them. Here, we actually placed a radiological source on a patient so that the radiological survey meters, the Geiger counters, will actually click when finding the right area that is contaminated on the patient. And lastly, avoiding hypothermia. This is a exercise that I participated in with some of our armed forces, and I really loved their strategy of thinking about the hypothermia and keeping the patients dry from the get-go with pre-stationing the emergency hypothermia blankets at all the patient treatment areas. So once you slide the patient off, you can immediately start wrapping them up to keep them warm and dry. Okay, I think we're finished with the video. We can keep going to the next slide. Think about space considerations, where all these patients are going to go once they are deconned and how you're going to divide up your area into different treatment zones. Next slide. Just a plug that your decon plans should integrate well into your overall MCI plans. They should not live in silos. For places, for institutions that are looking for help with their overall MCI MCI plans, I think a good starting point is the 15 till 50 program, meaning you have 15 minutes to receive 50 patients. And this is a guide for healthcare entities to help them develop these plans. And there's a link to it at Resource Central on the slide. Next slide, please. There's other great resources out there. This is one that we pulled from Lurie Children's Hospital. It's the Pediatric Decontamination Checklist. This checklist is agnostic to what type of equipment you have at your medical center. So I think it's a good starting place for centers to start thinking about their decontamination plans and what they might need and considerations to take into account for their plans. So this is a great resource to reference. Next slide, please. So I thought it'd be helpful to frame some conversation for the breakout groups with a scenario. So that is actually a photo from the East Palestine train derailment. So if that looked familiar to some of you, that was only a few years ago now. So your hospital's emergency department is notified by an EMS alert of an evolving MCI involving a train derailment. A school bus and a childcare center were in the immediate vicinity. Details are sparse, but you anticipate a large amount of patients to local hospitals. Next slide, please. You get an update from the field. There's multiple people collapsing, ill appearing, sweating, vomiting, and seizures being reported. There's suspicion on scene for a possible organophosphate exposure from the freight train derailment. And the symptoms that I gave you here are consistent with organophosphate poisoning toxicity. So you can go with that for your conversations. Next slide, please. So I think at that point, we would stop and we'll talk about maybe some more of what this looks like at your centers and what challenges might be in your plans in the breakout groups.
Dr. Goldberg, we have a small enough group where we're going to stay all together in a large group. And so we'll go ahead and talk about anybody who wants to speak up, talk about, or even add to the chat, talk about what important takeaways did you get from Dr. Goldberg's excellent presentation? Can you go back one slide, Nancy? What strengths and gaps have you identified in your own plan listening to his presentation? And what next steps might you take when you go back to your healthcare facility to discuss what you learned here today? So whoever wants to start and talk about any of those topics, please go ahead. And if you're shy and don't want to speak up or have microphone problems, just go ahead and put your comments in the chat. One thing I wanted to mention while you're thinking of your question or your comment is in previous presentations for the TICD, we have talked about where you can get resources for the equipment and supplies that Dr. Goldberg has mentioned. So please review back to the presentations where we've discussed decon. We've had some other excellent speakers talk about these topics. Children and youth with special healthcare needs. We had some details previously on that from the perspective of a parent and caregiver of someone with special healthcare needs. And so just to start thinking about going back to those presentations and incorporating that, adding to what you heard today, and starting to put together some really important pediatric considerations. One thing I wanted to ask about Dr. Goldberg is, you spoke about Hollywood, and what you see in the movies isn't necessarily real life. So a lot of times when we see an exposure like you've talked about, it's this big isolation room and, there's all this stuff that goes on while somebody's in isolation. I imagine that would be extremely scary for a little child to be in isolation. Can you talk a little bit more about that and what considerations that your facility has incorporated for isolating a child that's been exposed? Thanks.
Yeah, so I think when looking back to some of those pictures and when you're thinking about a contaminated patient going through decon trailers, showers, and being in those kind of isolating situations, I think some keys that to think about when developing your plans is one, you're going to need probably more staff members available to assist in the decon than you would for adults. Adults have their own challenges. We're heavier on average than the kids, but you're going to need people like in the apparatus, really, hand-holding, walking, and caring for the children through the process. You're not going to be able to direct, a 3-year-old or 4-year-old through this just with verbal directions. The second piece that ties into that nicely is really make all attempts not to separate families. Let them and encourage them to undergo the decon process together and assist in having the parents or caregivers assist for the pediatric patient through the process and making sure your plans allow for that. The goal is to avoid isolation as much as possible. So to get the patients through this in a timely manner and get them into a safer cold zone or treatment area where they no longer have to be in such an isolating environment. And I will say, just to spur any more conversation, is our plans are constantly evolving. And every time we actually do an exercise or a drill, we are constantly learning new things and adapting our plans to all of the challenges of caring for pediatric patients in this situation. We just recently had experience taking care of some people in the real world with tear gas exposure, and it was only 2 people, and we learned a lot just from taking those people through some more basic decon at our institution.
Thank you. So did anybody think of, thank you, Dr. Walter. Thank you for that comment in there. It's an excellent contact to have in your emergency operations plan or your annex for CBRN response. Anybody have any key takeaways or what really stood out to you in this presentation?
Yeah, Irene, I can go. Thanks, Brad. That was a great talk. I just recently went to the HURT course in Anniston, and between our tabletop and then going to the HURT course, I came up with a lot of issues that my local hospital is going to have, being the sort of big trauma center for the Central Texas. The biggest thing, and I think Dr. Goldberg mentioned it a couple times, was the children with special healthcare needs and the difficulty managing their devices, which are very expensive and very unique to the individual. I think we'll probably in this group discuss that a little bit more deeply as this collaborative goes on. But during our tabletop, we brought it up multiple times how difficult it's going to be if there is any sort of behavioral modifications or just truly equipment modifications that need to be made, and how we're going to deal with those. And then the other thing that my colleague and I came up as sort of an issue when we were in Anniston was, really trying to figure out the throughput of patients and the speed with which you can move them through. If you don't have to set up a full decon area and you only have 2 or 3 patients, that is a huge non-lift as opposed to setting up an entire decon. So if you're at Palestine and you have a train derailment and 25 to 30 people might be heading your way, I think that's one scenario versus 2 kids with tear gas who might be able to then just kind of move through your actual shower. So I think, again, throughput and amount of people and speed become a huge issue.
Thank you, Johnny. Anybody else want to make a comment? Of course, feel free to go ahead.
Yeah,
Go ahead.
I can add something. Just it's important to maybe go through your hospital and check out what your decon setup looks like. When I got to my first hospital as emergency manager, my 7th day on the job, we had a train car derailment that spilled white powder all over a neighborhood, and we had people self-report to the emergency department and went to decon them, and the showers sprayed up in the air. Some of them sprayed up in the air. They all sprayed cold water. And ED staff were like, you're contaminated. We don't know what the powder is. Can't let you in. And it was a mess. And so to avoid that, just test out your gear. And not just one time. Maybe think about doing it a couple of times a year, because things change. So that was a fun on-the-job quick learning experience for me that I will share with you. Just when you think everything is working right, it goes a little sideways.
Yeah, and don't forget about your fire and EMS partners. So those are another huge resource that can help you in developing plans, particularly for what Dr. Eisenberg was saying about the large scale events. A lot of fire departments have the capability to come on site and provide assistance in decon with their own apparatus. And you're going to have subject matter experts from those fire departments to assist you. So don't forget to include them in planning.
Just a word on support that you can get for planning, training, and exercises and equipment. I mentioned earlier that we covered some funding resources in a previous previous session. But if you live in a community that's supported by several federal agencies, like where I live in Las Vegas, we have a Department of Energy presence and a Department of Defense presence, and every alphabet soup in the federal government presence. And they oftentimes have either grant funds or they can provide technical support to you for planning, training, and exercises. So don't be afraid to reach out to those federal partners. Typically, you can do that through your local or state emergency management office or through your healthcare coalition to be able to bring in those resources that they offer at no cost to your institution or your facility. And just an idea of how to leverage those resources, because your staff resources alone can get very expensive at the hospital level, and we understand that. But leveraging the community resources and federal, state, and even tribal resources that you have available to you can help you go further in your preparedness. Any other comments or questions? Thank you to those who are putting items in the chat. And Laura, thank you for that comment about animals. And I guess you mean comfort animals or other support animals. Bridget, do you have something you want to mention about that? Or our token veterinarian in the group?
Yeah, no. So animals are an important consideration because not just as pets, but also as service animals, not just for our children and youth with special health care needs or grown-ups with access and functional needs, but also for law enforcement with their service animals. So decon and animals can be tricky. I strongly, highly recommend if you're planning your decon setup to have leashes and muzzles available, because even though these animals are very well trained, they can also freak out during an emergency. So decon should go well, but if you separate a police officer from their canine partner, things can maybe not be quite amazing. Also, plan on decon taking a little bit longer with a furry patient, because you do have to get all the soap and water into their fur and then absolutely ensure that it is all rinsed out. And it's fun to practice deconning animals because it takes a long time. You'd be surprised at the other end of decon when you're doing survey and monitoring, making sure that there are no soap bubbles. You'd be surprised where you can find those in the hair of animals. So thank you, Laura, for bringing that up.
And kind of an interesting question I just thought of is, if an animal is showing signs, a support animal is showing signs of organophosphate toxicity, because they are also mammals, right? Do we provide antidotes? And I think that's, a question we're not going to answer today, but would be in the forefront of my mind if I saw, a service animal, seizing on arrival. Tough questions.
I love it, which is another important point, Dr. Goldberg, to invite while you're practicing with your community members. Almost every community that I've been a part of at least has a community animal response team that activates during disasters, and they're usually part of the Humane Society. So another fun thing for you guys to look up in your communities, have these members participate in drills.
Just a reminder, if you would like to look at previous presentations or resources that have been added, there's PPN Resource Central, of course, but there's also the TICD webpage under the DRC tab in PPN that lists all the presentations that we've made before and the supporting documents that go along with those presentations, along with other resources that we put in there at the start of this DRC process. Included in that is for radiation response for pediatrics, a paper that we wrote a year or so ago related to antidotes and countermeasures for radiation response for children. So if you're looking for specificity on what type of antidotes and what type of dosing, that's a good place to start. Any other comments, questions, thoughts from the group? We have Mark, we have Gwyneth, Tyler. I don't know if you wanted to add anything. Carolina, Yahira. Please feel free to speak up.
I thought the presentation was really helpful. I like the idea of the badges with faces, with smiling faces on them, because the decon suits are pretty scary for kids. So I think we're going to try to do that. And I like the AI generated system for simplifying, simplified table for antidotes and for nerve agent poisoning. I thought that was pretty interesting, trying to make that easier and simpler. So
Thanks.
we'll try to.
Thanks so much. Thank you so much, Mark. Mallory, we didn't hear from you either. Is there something you wanted to bring up or put in the chat? Feel free. Just making sure we include everybody who wants to speak up. Okay, let's move on then to the next slide. Thank you, Tyler. So just as a recap, we have captured the information that you've discussed here today. We're capturing the poll question information. You'll see another poll in just a moment. And those, as well as other information you've provided in terms of your priorities for next session. So we talked about August being a full group, and then so September, October will be, we're still working out, who exactly the speakers are and the exact topics. Deneen, do you have an idea of when the next infection control presentation, when those subject matter experts want to present next?
Yeah, sorry. I think we're just still working with the schedule.
Okay,
Thought it
great.
was
We'll work that
October,
out.
but yeah, not 100% sure.
Okay. We'll make sure and meet and work that out, and we'll make sure folks know well in advance what those next sessions are going to be. But the dates are already set. They're already in the calendar and on the website. And so we're just, we'll get details out as we know them. Next slide, please. Here's poll question number 2. And Laura, you have figured out how to launch the poll, I think. So this is about
going to try.
Great. This is about resources to provide that you need in order to move past your session. So if you wouldn't mind taking the poll.
Do you see it on your screen?
We do see it, yes.
Good, thank you.
Popped up great, Laura.
So we have the option of no gaps. I have everything I need. Need more checklists, policy, SOP templates. Need more plans and annexes and best practice examples. You don't have adequate staff training or time. Need more, and I don't know what we can do about that, but certainly we can give you some ideas on how to leverage those. Need more buy-in from C-suite for your activities. Need more resources on the web page if you see something that's lacking, or you'd like to see more information placed there. And maybe you were unaware, or you need more information on PPN Resource Central, which we can provide to you. So please fill out the poll. If you're having trouble with the poll, please let us know. Thank you.
While you're all finishing that up, I wanted to make a mention of something that we learned from the Disaster Networking Collaborative, which preceded the Disaster Response Collaborative, which was that having a letter of commitment signed by a C-suite member or other leader, plus the team leader, was directly correlated to an increase through the final evaluation. We learned of additional FTE positions on pediatric preparedness and or more money to support a position for pediatric preparedness or protected time. So we did not use the letter of commitment for DRC, but as we move forward into a future collaborative, possibly that might be something to consider.
Okay, we're going to end the poll due to time constraints. But it looks like we have a couple folks with no gaps, yay. And then staffing's an issue for one, buy-in issue for one, and more information on PPN Resource Central. Can somebody put in the link for Resource Central while we wrap up the session, please? Take the poll down and move on to the next slide. Okay, any quick updates, Johnny or Laura?
Next slide, please. Johnny, I think you were going to talk about the pediatric disaster preparedness self-assessment for children's hospitals first.
Nice job. That's a mouthful. Yeah, so the PD pack is out there. Hopefully everybody knows what it is and has registered. We do have a list of people who have registered, who have received it. I have not gone through and checked as closely as possible into our group. I will say the TICD group has the lowest enrollment so far and submission. So if we could put a little bit of a plug to our local hospitals to get it done. It's a little bit of a heavy lift, but it is very doable. And just get into a room with like 2 other people who know what's going on at the hospital system and just crank it out and then just fill in the gaps. It's really not that bad. But I don't want the TICD to be lagging so far behind. It's embarrassing. And we do use this data a little bit to sort of form some baseline metrics and data for our group. So the more people we have completing it, the better we will be for moving forward with our live simulations. Thank you.
Thanks, Johnny. If
Next slide, please. Go ahead, Laura.
Nope, that's totally fine. Here's the registration link for the August 5th collaborative session. And then the next TICD focus area session is on the 2nd. More information will come in the follow-up message. Next slide. You can see the code. Those of you that want CE know to log into the CE system or text the code to get your credit. Next slide. I just looked at the time. Okay, 2 seconds here. If you don't have the time now, there is the link for you to complete the session evaluation. All comments are welcome. We do use the information to move things forward and plan our future sessions. Thank you so much to all of our speakers and everyone who helped prepare this session, the slides, and especially Nancy for helping me with moving the slides along. Thank you all. We'll see you next month.
Thanks, everyone. Appreciate you being here. Mark, the CME code, it'll be on the slides. But Nancy, if you have the opportunity to show that slide really quick on the CME, that would be great. Because we have to move off and go to another meeting, but there we go.
One back.
Oh no, one more, Nancy. Back for the CME. There you go. So that session code BUWGUB.
Yeah, and I think you have 60 days. And
I
the
think that's
slides will
correct.
be posted as well. Again,
Th-
thank you so much. Sorry, we all have to hop to the next session.
Thanks a million, everyone. See you next time. Take care, and thank you, Dr. Goldberg.
Bye-bye.